Good morning. Today's lecture topic is auscultation of the lungs, the main respiratory sounds. Lecture associated of Professor Kholikova Dilrabo PhD, Andijan State Medical Institute, Department of Propedeuticus of Internal Diseases. Auscultation means listening the sound inside the body. We use stethoscope and phanindoscope. Types of auscultation. The ways of auscultation can be two types, direct and indirect. Direct by ear, indirect using a stethoscope or phanindoscope. More useful in the heart-reached place for the auscultation, subclavicular, axillary areas, comfortable of hygienic reasons. Indirect auscultation was first proposed by French physician Laennec in 1816. In 1819, this method was described and introduced into medical practice. Rules of auscultation. The key points of auscultation are following. The room should be silent and warm. The patient should be undressed. Clothing produce additional friction. The skin should be hairless or hair may be wetted with water. The bell of stethoscope should hold the thumb, the forefinger and press it firmly and uniformly to the patient's skin. The order of auscultation is similar to comparative percussion of the lungs. We use anterior, lateral, then posterior chest side. It is an anterior view. It is a posterior view. Then it is lateral, left lateral view. It is a right lateral view. Auscultation date must be evaluated in the order. The first, main respiratory sound. Second, changes of the main respiratory sounds. Third, adventitious respiratory sounds. Classification of respiratory sound. Main respiratory sounds are vesicular and bronchial. Adventitious sounds are rales, crepitation, pleural friction sound. Vesicular breath sound. Vesicular breath sounds are generated by vibration of the alveolar walls due to airflow in inspiration. A long, soft noise gradually increases and is heard through inspiration. Alveolar walls still vibrate during initial stage of expiration to give shorter expiratory sound during about 1/3 of the expiration phase. This is a normal vesicular breathing sounds picture. Inspiration is longer and louder than expiration, and no gap between inspiration and expiration. Vesicular breathing is also therefore called alveolar breathing. Vesicular breath sounds are heard normally over the most of both lungs. We can hear this side vesicular breathing sound. Changing of vesicular breathing. Character of the changes in the vesicular breath sound depends on alveolus quantity and quality that take part in breathing, speed and volume of airflow, quality of the surrounding tissues. Changing of the vesicular breathing. Changes in the vesicular breathing can be according to quantity, then according to quality. According to quantity, it can be increased and decreased. According to quality, it can be with increased exhale, harsh sound, cough will interrupted sound, and absent or inaudible sound. Quantity changes of the vesicular breathing. Decreasing of vesicular breathing is characterized by more quiet and short breathing with saving of inspiration and expiration ratio. It is a normal vesicular respiration picture. It is a decreased vesicular respiration picture. Okay, next. Physiological decreasing of vesicular breathing, thick chest wall, excessively developed muscular or subcutaneous fat. Then, pathological decreasing of vesicular breathing. Pathological decreasing of vesicular breathing can be as a result of following causes. The first, difficulty of passing air to the lungs because of compression of the airways by tumor, enlarged intrathoracic lymphatic nodes, cicatricial tissue, bronchial drainage function abnormalities due to inflammatory infiltration or significant edema, presence of viscous sputum or foreign body. Then second, abnormal distension of alveoli at inspiration due to elasticity decreasing, inflammatory infiltration, bronchopneumonia, lobar pneumonia in a 1 and 3rd stage, interstitial edema, destruction of alveoli. Then increased amount of replacement of the lung tissues by connective tissue. Third is diminished breathing, excursion of thorax because of the pain, syndrome, pleura, ribs, intercostal muscle, and nerves. Extrapulmonary reasons of decreased vesicular breathing as a result of accumulation of fluid in pleural cavity, hemopneumothorax, accumulation of air, it is the pneumothorax, accumulation of fluid and air, hydropneumothorax. Second reason is pleural thickening as a result of massive adhesion or tumor, significant increasing of thorax wall due to obesity, edema, subcutaneous emphysema. Then absence of vesicular breathing because of affection of its formation or conduction. Formation affection, complete bronchus obstruction by foreign body or tumor with a fusar pulmonary collapse. This is obstructive atelectasis. Second, conduction affection, accumulation of fluid or air in pleural cavity that leads to the pulmonary compressions. This is compressive atelectasis. Then at the same time is a barrier for the breathing sound conduction to the thorax surface. Increasing of vesicular breathing, increased vesicular breathing, more loud and long breath sound with a 7 inspiration and expiration ratio 3:1 due to rapid straightening of the alveoli at inspiration. It is a normal vesicular respiration. It is increased vesicular respiration picture. Increasing of vesicular breathing, physiological and pathological increasing of the vesicular breathing are distinguished. Physiological by forced and puerile breathing. Pathological occurs when air flows at increased speed passed through narrowed airways, inflammatory edema of the mucous, bronchospasm, in bronchitis and bronchial asthma. This increase in speed increases turbulence. The amount of noise made and expiration become louder and longer. In pathological condition with the acidosis development. Physiological increasing of vesicular breathing. Physiological breathing determined by good sound conduction to the thorax surface in physical exercise in asthenics. Then puerile breathing. Puerile increased vesicular breathing with the marked exhale in children 12-40 years old because of thin and elastic thoracic and relatively narrow diameter of bronch. Quality changes of the vesicular breathing, deeper vesicular breathing when inspiration and expiration are intensified. It is called harsh sound. The main cause is a result of marked and non-uniform narrowing of small bronch and bronchioles due to inflammatory edema of their mucus, bronchitis in tuberculosis, then focuses of pulmonary tissues consolidation that alternates with the intact tissue because of better sound conduction by dense tissue-focused bronchopneumonia, faster breathing, and increased ventilation of the lungs in case of elevated temperature in fever. Okay, thank you for your attention. Goodbye.